Hello, everyone. My name is Doug Drossman, and I'm a professor emeritus at the University of North Carolina and president emeritus and chief of operations at the Rome Foundation. And I have a practice, Drossman Gastroenterology. And I'll be hosting this session, which is to address the paper coming out in neurogastroenterology and motility on what elements in the physician-patient relationship contribute to patient satisfaction. Now, there's a story behind this, and I'm joined today by Dr. Ellen Stein, who's Associate Professor of Medicine and Gastroenterology at Johns Hopkins, and Johanna Ruddy, who's Executive Director of the Rome Foundation. And this topic is of real meaning to us because we at the Rome Foundation have also been involved with teaching communication skills. Then we went on to try to study it. So what I'd like to do is start by having Dr. Stein talk about how she first got in contact with us at Hopkins to run a program, which eventually evolved into the paper.
Thank you. It's a pleasure to be here today. So at Hopkins, we always strive to do our best, and we take any complaints very seriously. The division had experienced a few complaints over the years, but there was a little bit of an uptick, and we wanted to address the physicians with better education to help them and see if communication was a factor. And we sought help from our own institution, looking to see what the patient experience office could provide in terms of training. But we already did all the things that they said: smile, say hello, introduce yourself, speak clearly. And when we described the patient population that came to an academic center and the serious problems that they had, including a longstanding history of opiates, chronic abdominal pain, or difficult to treat conditions like chronic pancreatitis, they just didn't have a program for us. And the education that we got in medical school was generic: hello, how are you? How's your pneumonia, sir? Kind of not really addressing the DGBI kind of functional chronic disorders, or even difficult diagnoses like getting a diagnosis of pancreatic cancer or something that's really going to be life-altering. I went to DDW, and Dr. Drossman was giving the lecture on, it was partly communication and partly how to do neuromodulators. There were two sessions that I went to, and I was struck by how I learned something, which, you go to the sessions and you're listening and you say, okay, that's interesting, I'll take it back. But I really took something back to my practice, and it was something small, but it was like mind-altering for me. Dr. Drossman just described how to sit with a patient to make a good interaction happen. And I said, that can't be true. So I tried it out. I did the exact interval, and I pointed my feet the direction of the patient the way he said. I just turned to face them when we were talking, rather than being at the computer. And the computer is a big influencer in the patient relationship now. You're always facing the computer, trying to put in data. And I just changed just for a few minutes of the visit. It wasn't the whole visit. And my practice changed. Patients seemed happier. They were more engaged. I was happier. I was more engaged. And that little change was one thing that I took away from an hour-long lecture. So we reached out to Dr. Drossman, to Johanna, who had been part of a patient scenario at that session. And we asked, can you help us design an advanced communication course? And we were trying to target people who we considered lower performers who had more complaints. But really, we also have some amazing high performers who could benefit from this. And when I think about physicians today, we're overburdened, we're hurried because the patient requirements, there are sicker patients coming to the clinics, there's less time allotted per space, and everybody's feeling these pressures to get the data in the computer, to get through the visit, to get everything, and to make everybody happy at the same time. And there's a lot of pressure that people feel upon themselves. So giving people the tools to know how to be more comfortable in their own selves, in their own skin, and giving patients a little more of a voice. I think the pandemic is helpful in some ways because people, Michael Phelps and the tennis player, have come out about their mental health. And it's now better understood, I think, how important mental health is for both physicians and for patients. And I think that's making it easier to have these conversations about how important establishing a good emotional relationship is. And so Dr. Drossman and Ms. Ruddy were able to create a program for us. And what we did was we invited all of our faculty essentially to come and attend a learning session. It was a morning. We freed them up from academic responsibilities that day. And it was face-to-face session that we had for several hours. There was some reading to do before and after, articles that were relevant. And then there were a series of lectures that went to the whole faculty, including some of our nursing and our fellows, about how to manage neuromodulators and how to have good communication. We wanted to study its effectiveness or its effect in general, and to kind of see what were those factors that were associated with good relationships, with poor communication, high level communication, see if we can find some patterns. So we, before the educational day happened, sent surveys to patients who were in all of our clinics, amongst all of our providers. And we engaged with our front desk staff to offer a $10 gift certificate to Amazon if they would complete a survey about their experience. And we continued that after the intervention. And we got a lot of good information from our patients about how they experience things. We also had a survey for the physicians who were a part of the session, and we asked them how they felt, what they learned, if there were certain things they learned that were valuable to them. And we just asked some standard questions, but it was really informative to know that there was an impact on both the patients and on the physicians. And many of the physicians who couldn't attend that day actually came up afterwards and said, when are you going to do this again? I want to get in. Please let me into the session. So I think it was a good experience for us. It happened to be right before the pandemic started, and I think it offered a little bit of calmness and sanity about how to make a relationship happen, which helped us actually when we moved to telemedicine. And Hopkins just, I think, hit the 1 million telemedicine visits mark recently because telemedicine was highly adopted. I think the situation is a little different after the pandemic, but as we get back into face-to-face practice, everybody's going to need a little help getting back to being humans in public altogether again. So this will serve us well.
Thanks very much. That was a great summary. So we did have evaluation as well as training for the faculty, and then we had a survey for patients. And maybe after Johanna speaks, or maybe a little bit later, you could tell us qualitatively what the response was, and Johanna will show us some data. So Johanna, can you tell us this program? This is a program with Rome Foundation and Drossman Care, which is a program teaching communication skills, and you're a part of that as a facilitator. Tell us what the program was like at Hopkins. What did we do?
Yeah, great. So as Dr. Stein mentioned, we were invited to come in and give a day and a half, really a half day of lecture that was to, like she mentioned, to a lot of different providers, the fellows, the nursing staff, etc. And then we did a train the trainer program with those more high achieving faculty members who could serve as then trainers within the division and continue this on an annual or biannual basis with their faculty. So I was going to share just a little bit of that information that was really interesting. So here is a breakdown. Let me just go to full screen here. Well, I guess you can probably see that. So the breakdown of who was a part of the training and how many years they had been seeing patients. So you can kind of see a nice distribution of providers who were a part of it. And then we, as Dr. Stein mentioned, we surveyed them and asked them, how informative was this workshop, and how much did you learn? How much will this affect your practice on a day-to-day basis? And as you can see, the responses were really interesting, that they really found this to be beneficial, kind of nicely split between a fair amount and a great deal in terms of helping their clinical practice. And then we asked them, how much did you learn in the following areas? The basic skills, which was really focused more on active listening, providing empathy, how to elicit information in a clinical interview that would be beneficial in diagnosing or providing treatment options, nonverbal communication, just some of those basic high-level skill sets. In blue, you can see, still they learned a great amount from that. And then more digging a little bit deeper with the advanced communication, when we were doing patient simulation with them and helping them to really handle complicated patient scenarios, patients who had psychological comorbid conditions or histories of abuse and trauma, drug-seeking patients who, I recall doing a scenario at this training where we had patients who were combative, patients who were physically aggressive. It ran the gamut of situations that these physicians were experiencing in clinic. And so we wanted to help them learn how to better handle those situations. And so that was included in this advanced communication skills. And as you can see, very high remarks on what they learned in those areas. So all in all, it was a great experience. I personally really enjoyed it, meeting all of them, and just as Dr. Stein said, better understanding the pressures that the faculty were under with time, with complicated patients, with really wanting to meet the needs of the patients, but struggling with how to do that effectively. And Dr. Drossman and I were able to provide some nice tips and tricks for them. And I just go back to every time Dr. Drossman and I do these trainings, whether they're virtual or in person, Dr. Drossman always says, it's not what you do, but how you do it that makes the difference for the physician and for the patient. And I think that was very, very true in this training. And hopefully, as Dr. Stein mentioned, it's those little things that you can just kind of tweak that make a big difference in your care. So
I'd like to also add what this program involved. Carl Rogers talks about learner-centered learning. This was not a fixed curriculum where we gave lectures. It was multiple modalities. It started with lectures to get the groundwork, and then we went on to more interactive learning by showing a video and having discussion. And then we moved on to more facilitated role playing, where the faculty could play the role of the patient. And in that way, the learning is much more active. And so that kind of style is a program that we in the Rome Foundation are looking to do in other programs as well. But as we heard, and why we're here, is we decided to get some good hard data on what patients' expectations are for the care. Because if the doctor knows that, then they can meet the patient's need. So I'm going to share with you the summary of our study. And this is currently in press in neurogastroenterology and motility. And so the authors also include Olafur Paulson, who's our psychologist and who works statistician, Anne Marie O'Brien Lennon, who's also at Hopkins, Johanna and Helen. I just want to show you an earlier study we did of 2,000 IBS patients that looked at satisfaction with treatment, in particular satisfaction with the care by a physician. And you could see that only about 22 or 23% were very or extremely satisfied. Most were not satisfied. This is an article in JAMA where they asked patients coming out of clinic to do 2 words to describe the clinician And what you can see here was using word clouds that rushed, hurried, busied were the biggest item that the patients did, but there are many others, all on the negative side. There was a word cloud with positive, which included things like being professional, but not many items. So the objectives of this study is to take the patient cohort that we're seeing the doctors in the faculty for this meeting and look at the critical factors in this patient-provider relationship that would predict satisfaction with care. We got the items, we then did a factor analysis to see if there are separate factors that define those domains. We did some regression to assess the robustness of these factors in predicting satisfaction with care. And then we even went ahead and developed a short version that you could use in your medical centers to assess the value of the physician-patient relationship. For example, it could be used to evaluate the patient's perception of the clinicians they just saw as a means of providing feedback and also training. So we looked at 6 GI clinics at Hopkins. The measures included a satisfaction with care scale that our research group developed about 10 to 12 years ago called the Satisfaction 37, a patient-physician relationship survey, and this is the patient's form. We have a patient and a physician form, which measures the items that patients value in the relationship with their doctor. The GSRS, which is a measure of GI symptoms, the PHQ-4, which were anxiety, depression scores, and then other clinical and demographic variables. As I said, we did descriptive analyses, correlations, exploratory factor analysis, and linear regression. There were 173 patients, 2/3 female, a highly educated group, 60% college degree, 70% married, primarily Caucasian, and the diagnoses are shown here, very typical of most clinics, about 60% organic, 30% functional, and 8% other. About 40% were visiting the clinic for the first time. One interesting finding is that when we looked at the satisfaction care scale, 82% were highly satisfied with the care, very different from what we saw on the internet in that other study. And I think this is a reflection of it being a private clinic with faculty who may have been selected by Dr. Stein as being high quality in their own right. And that's reflected in this. But it gave us the information to parse out the particular factors that led to satisfaction. We had this physician-patient relationship scale, which was 32 items, but what we wanted to do was to eliminate items that were redundant, because patient satisfaction may have the same items as physician-patient relationship. So we eliminated the redundancy and we brought it down to a 21-item scale to correlate with overall satisfaction with care. Now, this is a very important slide. What this is showing is the correlation of the physician-patient relationship scale with the satisfaction. And so the larger the correlation score, the R score, the more important it is to the patient in meeting their need for satisfaction. And so let's look down the list. Think about this with your own patients. Does the patient like the doctor? Does the doctor know about the patient's case? This is what the patients want. The patient wants to know if the doctor accepts their feelings and point of view, is available, is responsive, checks to make sure I understand, and then we get into issues of trust, connectivity, friendliness, and so on. And then the negative factors are, the negative correlations was if the doctor seemed rushed, not concerned, rude, interrupts, and even doesn't do a physical examination, because patients do want to be examined. And doctors need to learn that it's not just whether you find something, it's the level of nonverbal engagement and showing that you care enough to the patient to do the exam. So we did exploratory factor analysis of the 21 items, and there were 5 factors that came out, which explained over 2/3 of the variance. And that included the concept of competence. And here are the items that fit in that: trustworthy, knows about the case, can be understood. A feeling of connection, accepts feelings, available, feels connected. Professionalism, as shown here, considerate. And there was one item that the doctor is willing to refer out when necessary. Well, we're not going to go through all of this, but basically we displayed the factor loadings greater than 0.445, and the items are shown here as we just showed before of what distinguished the 5 factors. So then we did linear regression to try to look at the robustness of these factors in predicting satisfaction. And it turns out that the adjusted R squared, or the variance, was 63%. The contribution and was the beta scale of 0.41, meaning that the competence scale was the strongest predictor, and then came connection, and then referring out. The other 2 items were not significant, so we dropped it out of the model. And so we looked at this, and what we did is came out with a 12-item scale. This is something a patient could do literally in 5 minutes. And what we took the key items, and we have that available on the Rome Foundation. You can use it in research or in your own clinical care. So to conclude, the quality of the patient-physician's relationship is a principal driver of patient satisfaction, as we showed. The items can be characterized into 2 domains: competence, connection, professionalism, considerateness, and willingness to refer out. And the 12-item scale can be a quality metric for clinicians, investigators, and healthcare systems for training and to assess clinical performance, and maybe even someday revalidation. I think it's going to be our job to hopefully provide enough of this training so that it becomes incentivized, so that you can get reimbursement for this and RVUs. So that's our survey. Comments from either of you?
I think, Dr. Drossman, the most important thing is that these seem like obvious reasons why patients would like their physicians, but it's not always obvious to the physician what they're doing that's disengaging them from the patient. And it was universally, no one was intending for anything to happen where the patient would have felt like they were rushed or the physician was rushed. It just happened in the visit. And I think one of the best skill sets that this session offered were some of the tiny changes that can be made in a visit that are actually possible for the physician to change in their daily practice, that brings this connectedness back, this centered patient visit where the patient feels heard and understood. And it didn't actually take more time. That said, to all the administrators listening, a little more time in a visit goes a really long way to build a strong relationship. And the patients are feeling the rushed nature of current medical practice, and they feel unheard. And when they feel unheard, they do things like go to the ER or urgent care because they don't feel confident that they got the right information or that they were able to express themselves. So it actually probably would save money to start adding back a little time to the visits. But I thought the lessons that the physicians heard were how to make their visits more valuable using the same amount of time. And I think with the emphasis on mental health, it was illuminating to me how distressed the physicians felt with the constraints of modern medicine, and that distress was reflected in feelings of burnout, worthlessness, feeling like they were inadequate. And often it was something that was redirectable, retrainable, and provided more joy to the physician. And I think that's something that's really, really important about the training, which was that it provided greater joy to the physicians. And that should be a huge focus after the pandemic and beyond. But providing clinician joy and a place or a space to debrief about physician practice. I think it doesn't have to be you talking about your mother to be a valuable mental health experience. It can be just talking about the day-to-day struggles that physicians experience. And I thought that those were how you role played Dr. Drossman with Johanna as a patient, and then back and forth, offered different ways for us to kind of digest the information and understand it. My favorite part was when we got to design the most challenging office experience.
Yes.
And I thought it was just me who was experiencing this, but it was a universal experience of the most frustrating or challenging situations in medicine. And I think that reflects the broader need for more education of this kind in clinical practice to improve the quality of relationships and to improve the experience.
Ellen, did you see was there any feedback that you can recount after the session by the faculty?
I think that people who had been frustrated with their day-to-day felt overwhelmed, felt more empowered to say, hey, this is what I need from my schedule. Adding on that extra patient didn't help. I think using the My Chart feature in Epic or the portal can be helpful, but those interactions, those short, terse interactions that you might get through a portal don't always encompass the whole conversation you want to have. And so some people shifted their practices to bring those patients in, especially as telemedicine was available. We made a little bit more space available for visits during telemedicine and saw very happy and satisfied patients because they had a little more access and we had a little more time to give when the shutdown happened. I think that the physicians in general experienced greater confidence in managing some of the complex pain patients because neuromodulators can seem very foreign or overwhelming if you're not used to using them. And so I think it offered a lot of information about how to use those things in a more positive way. It's often seen as a negative to not give narcotics to treat pain because that's an expectation. But when you talk, Dr. Drossman, about how to use the neuromodulators to improve long-term symptoms and really make a meaningful difference, I think it helped people to feel more confident in those medications and start to build their practice confidence and to be able to treat things themselves rather than having to always refer out to a pain prescriber.
Well, thank you. This program is available through the Rome Foundation if other medical centers want to do it. We also have, I'm going to show you one more slide. Johanna and I came out with a book, which is actually doing quite well. It's only a few months out, called Gut Feelings. And a big part of the book, there's a section on all the disorders of gut-brain interaction, but it's meant for patients and doctors. And over half the book is on communication training, learning about how to communicate verbally and non-verbally. So if you're interested, either go to the Rome Foundation or check out this website. Well, I think our time is running out. Johanna, any last minute words?
No, I think this is great. And I think this is a great program for increasing both patient satisfaction, but as Dr. Stein said, physician satisfaction, which we know is really at an all-time low right now. And so really providing those skills for providers to be more empowered and to feel more, say, appreciated, honestly, and have better outcomes with their patients is really key. So this is a great program. Thanks, Dr. Stein, for inviting us. It was a lot of fun. So.
Thank you for coming and helping us.
Bye.